I'd like to welcome everybody to this seminar that is presented by the Swedish Society for Emergency Medicine. My name is Michael von Schickfuss, and I'm the chairman for SWESEM, the society. And I work clinically as an emergency physician in the emergency department and in intermediate care in Norrköping. Now we will talk about COVID-19 and VTE complications. I think we all know that this has been a very commonly discussed topic during the pandemic. It has not only been discussed in scientific publications, but also in public media and a lot in social media, different social media platforms by colleagues, and there have been quite differing results from different studies. So this has been a very engaging topic for the last one and a half years. And today we will take a close look at two different studies that used a different methodology for their results and also came to differing results. So this will be very interesting, I think. The schedule for the seminar is that the first group will present their study, and after that we switch to the second group presenting their study. Then we get an expert commentary on the studies and also on the statistics used. And in the last part of the seminar, we open up for questions from the audience. So first out, I'd like to present Matthias, Jörg, Jens Wretborn, and Daniel Wilhelms from Linköping, who will present the first study. Matthias, Jörg, and Jens Wretborn work as emergency physicians in the emergency department in Linköping and Sundsvall. And Daniel Wilhelms is also the head of R&D at the emergency department in Linköping and associated professor. They will present their study that was published earlier this year in JSEP Open, risk of venous thromboembolism in the Swedish healthcare system during the COVID-19 pandemic, a retrospective cross-sectional study. So please welcome Matthias and Jens and Daniel.
So we have this paper published in JSEP September 2021, and our approach was like, you all maybe remember this picture. It was March 2020 and Corona arrived to Sweden finally, and for us as frontline workers it was quite challenging. I literally remember coming to work every day and there was new regulations, new recommendations, so it was quite hard to keep up with what is right or wrong. And we assessed a lot of patients with breathing difficulties in tents like this on the picture by actually only visual appearance, saturation measurement, and maybe a respiratory rate. Quite unusual as we would do. Most of these patients we sent home and we didn't really know how they will do. And at the same time, we had these reports in media and also a lot on social media about increase in venous thromboembolism in this patient group of COVID-19 positive patients all over the world. And this was often subjective impression. So of frontline workers, it was quite hard to tell, hard to measure, is this true or is this just a feeling that it's more? And scientifically, there was not that much data by then. And the first study who came out in the beginning of April was directly from Wuhan in China, who showed for 81 ICU patients that they had a prevalence of VTE at 25%. And just not even 1 week later, there was another study coming out, this time from the Netherlands, where they showed for 184 ICU patients a prevalence of 31% for VTE. And 3 weeks later, Helms et al. From France showed a slightly lower prevalence at 17%. And that's quite hard to know if this is a lot or little if you have nothing to compare. So if we see an ICU population, a general ICU population, we can use the PROTECT trial from 2011. These were over 3,700 patients, and in this population, the VTE rate was at about 7%. So our next question was then, are there other studies who look at VTE and maybe infectious diseases prior to the pandemic? And we found two studies. One was from Kaplan from the year 2015. This was a USA-based study with 105 severe sepsis patients on ICU, where they found a prevalence of 37% for VTE. And another study of Obi et al., also from the US in 2019, where they had a subset of ARDS patients, so severe course of disease for influenza patients, where they found a prevalence for VTE at around 44%. So it feels that we have some kind of clue how it looks for the ICU population, but we still don't know how it looks for the ward, and not for the most important group at the emergency department, for us, the outpatients, which is the biggest group we take care of. So that was where we started our study and designed this retrospective observational study by looking at the cohort of all the adults in Region Östergötland who for some reason did a diagnostic test for VTE. And our time window was March 1st until the last of May. And with that, we covered the biggest part of the first wave of COVID-19 in Sweden. The outcome measure was a pulmonary embolism, or a DVT, and the exposure, of course, was a positive PCR test for COVID-19. To exclude other causes for VTE, we chose the following confounders, which are also known risk factors for VTE, and also included in clinical decision rules like Wells score. And we also checked for the level of care to differentiate ward, ICU, and outpatient groups. We compared this with the same time frame, the same cohort in the years 2015 to 19 in the whole of Östergötland to get an idea how things changed. So here you can see the data set. We had almost 10,000 diagnostic tests in the beginning, CTPAs and ultrasound who looked for DVT. After exclusion, we had a full cohort of 8,702 patients, and they were divided in the control or comparison group 2015 to 2019 and the 2020 group, which had 1,398 patients. And this group was then divided in COVID positive 88, negative 546, and not tested 764. And these numbers, as most of you know, are related to the poor test capacity which we had in the first wave, where only patients who really were admitted to hospital were tested. If we look on the first result table, you can see on the left the comparison group 2015 to 2019. In the middle, we have the 2020 cohort, and the subgroup of this cohort, the COVID positive patients. We have approximately the same age, but in any other concerns, we found a bit what we expected for the COVID positive group. They were more men than female. They were sicker. They had more ICU care, more ventilator treatment, and also a higher mortality. On this slide, we want to show you the annual variation of the VTE cases in Region Östergötland from 2015 to 19, but also to 2020. And here you can see this is a fairly stable course for the whole VTE and also the subgroups pulmonary embolism and DVT. And here we can say our assumption was that even if we only have small amount of COVID positive cases, as this was a really high community spreading in the first wave, we would we wanted to see some signal in our data for 2020 that VTE would go up, but we cannot see this in this data. If we look just in the 2020 cohort, we have the 3 groups, and we can see that for all the groups, the VTE prevalence is about 16%, no matter if you were COVID positive, negative, or if you were not tested. And on this slide, I want to take some minutes to explain this slide, where you can see the prevalence of VTE by the treating unit. To the left, you have ICU and ward, and these were patients who were at least 24 hours on the ICU or on the ward. And to the right, you have columns for ICU admission and ward admissions, and these were patients who coming to the emergency department and were admitted. And the first 24 hours after this they come into the left group. Why did we do that? For us, it was important to see somehow the stage of the disease. It is important for us to know if the patient comes at day 6 or 7 with a COVID infection, if they actually already have a VTE by then, or if they develop it later on, if they are on the ICU or in ward and develop a VTE day 3 or 4. That's like different things, and they have different risks. So that's why we separated the patients we meet, sending them home or admit them, and the patients who actually were in the hospital for a longer time. So if we start with this group to the left, we have the ICU patients, and we see that there is a higher prevalence for VTE for the COVID positive patients, almost double the amount of the pre-pandemic level. For the ward, we see that there's less VTE findings in the COVID positive group compared with previous years, but otherwise there's no significant difference between the groups for COVID negative or unknown group. And for the outpatients, it's almost the same pattern, slightly a few percents less, but the picture is the same, with no increase for VTE with COVID positivity. And if we look on the ICU admissions, so a patient comes into the emergency department, we see that the patient needs to be admitted to the ICU, but the ICU registrar wants us to do a pulmonary embolism CT to check for pulmonary embolism before the patient gets admitted. In this group, we cannot see a higher prevalence for VTE in patients who are COVID positive. And for the ward admissions, we see a 10% rate there, but it's also lower than the years before. So this is some of our most important conclusion of our data, that ICU patients seems to drive the higher VTE prevalence in this, but and maybe also in other studies, but not the patients who arrive directly to the emergency department, and the patients we meet and the patients we send home. So these seems to be 2 different groups. And yeah, this could have been overlooked by other studies who didn't differentiate by that. And also here, we would have expected a more clear signal in our data if COVID-19 would be a significant risk factor leading to VTE, then we would have expected more findings in the outpatient or the ward group overall. Of course, our study also has limitations. One is we have a selected cohort in 2 ways. The first is that a physician ordered a VTE test. Somehow this physician thought of, oh, this might be a VTE. And there we introduced some kind of individual assessment for each doctor in Östergötland, which we cannot control for. So a better approach would have been to maybe include all patients who come to the emergency department for shortness of breath and start from there. So this would have been better, but also harder to do. We also had these very limited testing capacities, and we might have patients who were in the wrong group in our data set. They might have been COVID positive, but were not tested, or they are not even in the data set because we didn't check on them. Concerning the power, we were underpowered concerning this small group of COVID-19 positive patients. which led to confidence intervals which were wider, and yeah, for a number of items we checked, so that this was definitely a limitation. And maybe the most obvious in this, as it's a pandemic and we just do things very differently than we have done them before, it's hard to say if this changing from normal practice changed our results and the prevalence to it. So to summarize, in our data set, we can't find an increased risk of VTE with COVID-19 positive patients. We have a high prevalence of VTE in ICU patients with COVID-19, as it was shown in previous studies. And there was no difference in Östergötland in the VTE prevalence between the group of 2020 and the comparison group of 2015 to 19. So this was the end of our presentation, and we're looking forward to answer your questions later. Thank you.
Thank you very much, Matthias. So in your study, you couldn't find a higher risk for VTE in COVID-19 patients. Then we go on to our next study. It's a study from Umeå. The presenters will be Anne-Marie Fors-Connolly and Paddy Farrington. Anne-Marie is a MIMS clinical research fellow and is doing a university residency in clinical microbiology at Umeå University Hospital. Her research group combines epidemiology, clinical and laboratory-based research to answer questions regarding complications following viral infections. Paddy Farrington is Emeritus Professor of Statistics at the Open University in the UK, and he now lives in Scotland. He collaborated with Anne-Marie and her team on the Umeå study we are discussing now. The most impactful paper from this group was published in the Lancet this summer, where the risk of acute myocardial infarction and ischemic stroke following COVID-19 was determined using the same methods that we will talk about now in this presentation. This study is not published yet, so it's the first time we will hear about it. It's called Risk of Venous Thromboembolism and Bleeding Following COVID-19 in Sweden, a self-controlled case series and matched cohort study. Please, Anne-Marie.
Thank you very much. And I will share the presentation. So can you see the presentation? Yeah, perfect, excellent. So thank you very much for allowing me to present these results. They are currently under review, and I'll be talking today about that we found an association between COVID-19 and thrombosis and bleeding. So basically the aims of this study were to determine if COVID-19 increases the risk of DVT, pulmonary embolism, and the other side of the coin, if it increases the risk of bleeding. So in order to answer this question, we needed data, and every individual that tests positive for SARS-CoV-2 infection is reported to SMINET, which is a database at the Public Health Agency of Sweden, which means, and this is because it's a notifiable disease, which means that every single individual in Sweden that tested positive is found in this database, or at least their personal identification number is. So we retrieved the personal identification numbers from all individuals that tested positive between February 1st, 2020 and 25th of May, 2021. This data file was sent to Statistics Sweden, SCB, and they matched 4 control individuals matched on age, sex, and county of residence in Sweden. And the personal identification numbers for this matched cohort was then sent to the National Board of Health and Welfare, Socialstyrelsen, and they cross-linked the identification numbers with the outpatient registry, the inpatient registry, so all hospitalizations, the cause of death registry, and the cancer registry. And in our study, we wanted to look at the first event. So we retrieved historical registry data from the outpatient and inpatient registries. From the outpatient registry, we had data from 1997. And from the inpatient registry, we had data from 1987. The Swedish Intensive Care Registry also sent their data regarding COVID-19 patients to the National Board of Health and Welfare. The personal identification numbers were removed and replaced with a study ID, and then that data file was sent to me and my group. So the outcomes in our study was the first occurrence of a deep vein thrombosis, pulmonary embolism, or bleeding. And in order to identify this first event, we used International Classification of Diseases diagnosis codes version 9 and 10. And if they had had any event during any of this time point, 1987 to 20, before a study period, they were excluded from a study. And the reason for this is that if you've had a prior event, the risk of a recurrent event is increased. And we wanted this to be as statistically stringent as possible. As Matthias informed us, there are indeed covariates, confounders, that also increase the risk of thrombosis and bleeding. And in order to get around this in this registry data, we identified if individuals had had cancer within 6 months of the COVID-19 or the index date for the control individuals from the outpatient and inpatient registries. We also identified using the intervention codes if the individuals had had surgery 1 month prior to the risk period in the outpatient and inpatient registries. And then we calculated the Charlton comorbidity index using the historical registry data from the cancer outpatient and inpatient registries. So we used 2 different methods to determine if there was an association excuse me, between COVID-19 and thrombosis. And this method uses cases only. And what's really interesting is that Paddy Farrington actually invented this method, and he is here with us today and can answer questions on that method. He also performed the analysis. What this method does is it takes only cases or individuals that have had, that were COVID-19 patient and have had a deep vein thrombosis or pulmonary embolism and bleeding. Now we look at the study period from 1st of February 2020 to the 25th of May 2021. And we then divide this period relative to the COVID-19 date into risk periods of first week, second week, first month, second month, third month, and up to 6 months after COVID-19. We then use the rest of the periods as control periods. So it's if the incidence is increased in the risk period compared to the control period, then we expect it to be higher than 1. We also included a buffer period because there could be a bias that individuals that came in with a pulmonary embolism then got infected nosocomially. And we also included a buffer period 3 days prior to the COVID-19 date, since there could be some delay in testing. So in this study period, we had, first of all, we had a total cohort of approximately 1 million COVID-19 patients. We had 1,761 first events of deep vein thrombosis, 3,267 first events of pulmonary embolism, and 7,927 first events of bleeding. We then performed a matched cohort study, and this was to compare the incidence of outcome with the background population, and that was using the matched controls. So we had, in that cohort, we had approximately 4 million control individuals, and we only looked at the risk in the first month after COVID-19, or the index date for the control individuals. And when we look at the results, what we found was that the risk of a DVT was increased significantly up to 3 months after the COVID-19. We don't include the COVID-19 date, day zero, as this introduces quite a high risk of bias. As you can see in the time period -3 to 0, that is where the risk of a DVT is approximately 9-fold increased. So we removed this day, and then we see that in the first week, the risk of a DVT is increased approximately 5.6-fold. The second week, 7.4-fold, and then it decreases, but it is significantly increased up to 3 months after. When we look at pulmonary embolism, the risk of a first, now remember this is a first, not recurrent, first pulmonary embolism is increased 6 months after COVID-19 date. We find that the risk is actually increased in the second week, 46-fold. and then decreases but stays significant up to 6 months after. We also see that the month prior to COVID-19, there is an increased risk, and we interpret that it's an indication of a nosocomial infection, that the individual came in for the pulmonary embolism and was likely infected at hospital. And when we look at bleeding, the risk of a first bleeding is increased up to 2 months after the COVID-19 date. And in the first week is approximately 3.5-fold to down to 3-fold, and then goes down to 2-fold. And it's also increased in the pre-exposure period, 5-fold, which is likely too high. And then also there's an increase in the month prior to COVID-19, thereby also indicating a nosocomial infection. So then we did the matched cohort study, and then we also, in parallel, did the self-controlled case series study in order to compare the two, the relative risk and the relative incidence. And what we found was that in the first month, and remember this is excluding day 0 and it's the first event, that the risk of a first event was increased approximately 5-fold in the first month, and using the self-controlled case series study, the relative incidence was approximately 6-fold. So I would say they're quite comparable. Similarly, for pulmonary embolism, and this was the highest for all outcomes, the risk was increased 33-fold. And this is using the whole cohort and the background population. And similar for the self-controlled case series studies, the relative incidence is increased 32-fold. And when we look at bleeding, the relative risk is increased approximately 2-fold compared to the background population on matched controls, and approximately 2.5-fold using the self-controlled case series study. So we also wanted to stratify across disease severity because we believe that patients in the ICU likely had higher risks. Now we used the matched control individuals as the reference. And what we found that the risk of, again, this is a first DVT, the risk of a first DVT was approximately 3-fold increased in mild patients. And mild is they did not need hospitalization and they did not need intensive care at any time point. Hospitalized COVID-19 patients had an approximately 20-fold increased risk of DVT. And if you're looking into intensive care, these individuals had approximately 31-fold increased risk of DVT. If we then look at pulmonary embolism, mild patients that did not need any type of healthcare had approximately 7-fold increased risk of a pulmonary embolism. If you're hospitalized, your relative risk increased 139-fold. And if you're in intensive care, the risk of a first pulmonary embolism increased approximately 280-fold compared to the background population. Now, interestingly, when we look at the first event of a bleeding, if you see mild COVID-19 patients actually did not have a significantly increased risk of bleeding compared to the background population. Whereas if you're hospitalized, you had approximately 8-fold increased risk of bleeding, and intensive care 23-fold. And why that is, it could be due to the anticoagulation or the thromboprophylaxis treatment, possibly. We then wanted to look at what is the risk of these outcomes across the different pandemic waves, because treatment guidelines changed throughout this time period. So we stratified into 3 waves. The first wave from February 1st to July 31st, 2020. The second wave from the 1st of August to 31st of January 2020. And then the third wave, 1st of February until 25th of May. And the 25th of May is the end of our data set. And what we found is for deep vein thrombosis that the risk of a first-time deep vein thrombosis was increased 15-fold, and then decreased during wave 2 and 3 to approximately 3 and 5-fold. And again, this is compared to the background population, the matched control individuals. When looking at the pulmonary embolism, we found that the risk of a first-time pulmonary embolism is 52-fold increased during wave 1. In the second wave, it's increased approximately 25-fold, and then interestingly, it increases back up to 44-fold in the third wave. And then for bleeding, the risk of a first bleeding is approximately 4-fold increased in the first wave, and then it's decreased to 1.5-fold and 2-fold during wave 2 and 3. So to summarize, in our study, we found that COVID-19 is an independent risk factor for deep vein thrombosis, pulmonary embolism, and bleeding. That the risk of deep vein thrombosis was increased significantly up to 3 months following the COVID-19 date, and was approximately 5 to 6-fold increase the first month compared to the control individuals. That the risk of a pulmonary embolism was increased up to 6 months following COVID-19 and was approximately 30-fold increased the first month following COVID-19. And the risk of bleeding was increased up to 2 months following COVID-19 and approximately 2-fold increase. So this study was a team effort, and I would like to thank the members of my research group, Yanis Katsoulas, of whom I'm a co-supervisor, Hanna Jendal, who's my PhD student, Osvaldo Fonseca Rodriguez, who is an epidemiologist, and Erling Lundevan, who's a statistician. My collaboration partners, Krista Lindmark, who is a consultant in cardiology and intensive or internal medicine, and Malin Sund, who is a professor and also consultant in surgery. And last but not least, Paddy Farrington, who invented the self-controlled case series method and performed the self-controlled case series analysis, and who is here with us today. And of course, the funding and all of the illustrations were created with PyroRender.com. So, thank you for listening as well.
Thank you, Anna-Marie. So this was a study with a very large data set and a different methodology and different results compared to the first study. For the last part of this seminar, when we take questions from the listeners, I'd like to write all your if you could write all your questions in the chat, so I can then take them from there. So, and you can start doing that already now if you want to, because I think you can't ask your questions yourselves in the system. So please write them in the chat function. Next up, we have an expert commentary from Ulf Ekelund, who is an emergency physician at Skåne University Hospital at Lund, and also professor of emergency medicine at Lund University. Welcome, Ulf.
Thanks so much. Can you see my screen?
Yes, we can.
Yes. Okay. So I would just like to say a few words on why I think these COVID and VTE studies are interesting and important. The first thing I'd like to mention is that VTE is a pretty big thing in Sweden. We have almost 200 new VTE cases per 100,000 inhabitants a year, and that puts VTE up there with the other big serious disease states like acute myocardial infarction, stroke, and breast cancer. And VTE is not only a big thing in society, it's a big thing in the emergency department too. So each year we have about 350,000 patients with symptoms compatible with VTE, and that's a lot of patients. We send about 30,000 patients each year for diagnostic imaging for suspected pulmonary embolism, and at least as many for suspected DVT. So the other reason why these studies are interesting is that COVID checks almost all the boxes in the VIRCHOW'S triad, the basis for thrombus formation. There's an endothelial injury, there's stasis and mobilization, and there's also a hypercoagulable state. So there are plenty of basic science reasons to believe that COVID patients might have a VTE if the symptoms are right. The third thing is that there's an overlap in symptoms in COVID and pulmonary embolism, which causes a diagnostic challenge. So this is a list of some of the symptoms patients might have in COVID. And the ones to the right are the emergency symptoms that should lead to emergency care. And a substantial number of these symptoms, the red ones, are the same as in pulmonary embolism. So if you get a patient with these symptoms, the question is, does the patient have COVID, or does he or she have PE, or perhaps both, or perhaps something else like heart failure or bacterial pneumonia or something? So in this situation, of course, it is important to know the frequency of VTE in COVID patients. The last thing I'd like to say is I'd like to remind us all that estimating the likelihood of VTE is not the same in different situations. So these are the general risk factors for the long-term risk of VTE. And these risk factors are not the same as those at the risk factors that has been shown to be important in a short-term prediction of VTE in the emergency department and in symptomatic emergency department patients. This is the Wells score. And they are also not the same as the risk factors in the PERC score that we use for predicting the short-term risk of VTE in low-risk patients in the emergency department. So the risk factors are different depending on the situation and depending on the patient. So with that, I'd like to leave the screen again to the authors and perhaps to the audience and Mikael. And the big question here is of course, are the study results compatible? And I suggest they are. So Wretborn et al, they found that in patients sent to imaging for suspected VTE, the risk of VTE was unaffected by COVID status. And Katsularis and collaborators, they found that in patients with COVID, the risk of first VTE was larger than in the general population. Thanks for the attention. Back to you, Michael.
Thank you very much, Ulf. Now I would like to invite Paddy Farrington to talk about the statistics used in the two different studies with his statistical background.
Okay. Well, first of all, I'd like to express my thanks to the organizers for inviting me. And I'll keep my remarks very brief. I don't have a presentation to show because I think the ideas I'm going to present are actually quite simple. I'm not going to go into any deep statistical detail because I think the key issues lie elsewhere. In a nutshell, I think that these are both good studies and that their results are not contradictory, but should be understood as complementary. So just to give a quick overview, the two studies used very different designs. The Linköping study was cross-sectional with also a comparison between pre-pandemic years and 2020. The Umeå study used two methods, a self-matched method and a matched cohort method, which gave similar results. Essentially, I think that the specific statistical designs used were fine. There's no particular problem associated with those. I think the key point is that very different questions are being asked in the two studies. And to answer those questions, very different denominators are used. And so it's no surprise at all that they come up with very contrasting or apparently contrasting answers, simply because they're answering different questions. So the Linköping study asks, among patients with a clinical indication for VTE, does the proportion who actually have VTE vary according to whether the patients had COVID contemporaneously or not? And they find that it does not. That is, that the indication for VTE are similar in contemporaneously COVID positive and COVID negative patients. And in both groups, about 16% with indications for VTE actually have VTE. In contrast, the Umeå study asks, does COVID infection increase the risk of VTE over the baseline level which would apply if that individual had not had COVID? And we find that it does, and that the increased risk can last several weeks or even months. But you have to remember that the baseline risk relates to the general population and is exceedingly low. The absolute risk of VT in most COVID cases is a fraction of 1%, and only becomes appreciable if the patient is admitted to hospital and especially an ICU. And in the background population, it is considerably less than a fraction of 1%, which means that explains the high relative risks we obtain. If you divide a small number by an even smaller number, you can get quite a big number. So what do these show? These two studies show? Well, together they show that, or suggest that COVID increases the risk of VTE, but does not significantly change the clinical indications for it, except perhaps for patients who are unfortunate enough to end up in an ICU. And I think that is the reason for the differences between the study, which simply reflect different questions being asked of the data. Thank you.
Thank you very much, Patty. That was a brilliant commentary. It almost makes a discussion not necessary anymore. But now we will open up for this for questions from the audience. First question came up that was, how was bleeding defined in the Umeå study from Infektionskliniken i Gävle?
Yes, I'm going to share, and let me just see if I can find the table. So these are the diagnosis codes that we used, ICD-9 and ICD-10 for bleeding. So it's basically hemorrhagic stroke, GI bleeding, hemothorax, and also if you had postmenopausal bleeding. That's how we define. We also found it a little bit difficult to define what's clinically relevant bleeding. We also had an ICD-10 code for anemia after large bleeding, and that large bleeding could be anything. So if an individual had had any of these diagnosis codes, both in the ICD-10 or ICD-9, before a study period, they were excluded. So that is how we defined our bleeding.
Thank you. There came more questions to the Umeå group. In the self-control, how did you adjust if someone have had VTE and then is on prophylaxis?
Let's see, we didn't have that problem because I don't know if this is for bleeding, but if they've had a prior VTE, they weren't included. We only looked at the first-time events, because if you've had a prior VTE, you are also at risk of having a recurrent, and we didn't want that to confound our study. So we did not study previous VTEs. We only studied the first-time event of a VTE during our study period, which was from February 1st until 25th of May 2021. And then in the match cohort study was day 1 to 30 after COVID-19, or the index date.
Okay, thank you. Another question was, could it be that there is a bias for diagnosing VTE in COVID patients? In a lot of hospitals, due to the similarity in symptoms, there will be more diagnostics done. Moreover, in ICU patients, an ultrasound to diagnosing VTE was routinely done several times weekly, which could bias to diagnosing VTE in COVID patients, and also CT4P was done more liberally. That's a question to the whole group as well, but maybe Anne-Marie, what's your take on that question first?
Well, actually here I would like to refer to Matthias, Jens and Daniel's study that they show that the positive predictive value, if I understand correctly, was the same for COVID-19 patients and also for individuals who did not have COVID-19 patients. And to be honest, that's quite comforting, because I actually, that is one of the risks for bias of our study. If you are looking for, if you are overdiagnosing, then I would have expected that the positive predictive value would decrease in Matthias, Jens and Daniel's study. And it isn't, it's the same. So it seems that at least during the first wave that was not a problem. But of course, we can't guarantee it. This is a registry-based study, and it's we look at the first event. But it is, Paddy, maybe you have a comment?
Oh, I agree completely. I think we found the results from the Linköping study quite reassuring in that respect, because it was a concern that might be the case in our study.
Thank you. And the last question from Fredrik Kahn as well. Did you adjust that those admitted for COVID could have more underlying diseases predisposing for VTE?
Yes, we did. We adjusted. I didn't show those results. We adjusted for if they had a surgery within the month prior to the risk period, and also if they had cancer within 6 months, either way of the COVID-19 or the index date. And then we also took this index of comorbidity, charts and comorbidity index, to adjust for that. So the results that are shown are adjusted for these potential confounders. Yeah.
Thank you. Okay. At the moment, there are no more questions from the audience. Please keep on putting in your questions if you have any. I have a question to the Linköping group. You come to your conclusion that we found no increased prevalence of VTE in the general population compared with previous years, and no increased risk of VTE in patients who were SARS-CoV-2 positive, suggesting that SARS-CoV-2 status should not influence VTE workup in the emergency department. Do that last statement about the VTE workup in the emergency department, do the Umeå results influence that statement in any way for you?
So the short answer, I believe, is no to that question. So again, we totally agree with Paddy that the results are not necessarily contradictory, rather complementary, and it is our concern is that, at least in our perspective, there's no question that if you end up in the ED or in the hospital having a viral pneumonia and being quite sick at that as well, there's definitely an increased risk of venous thromboembolism compared to you just being out feeling fine walking in the street. So, but that's the same for quite a lot of different conditions as well, not just COVID-19, but probably similarly for influenza or for other illnesses as well. And the question we wanted to know a little bit more specifically is COVID-19 very different from other diseases? Because we take that into account when you come to the ED and visit us. And so in that sense, I was not particularly surprised by the results of the Umeå study. I think it's quite expected, with one caveat maybe. So if you have any, because I have at least one question for the Umeå study on their methodology. But if you have any more questions, Mikael, please go.
Maybe I can ask one more question that is close to the first one. Do you think that the risk for VTE and COVID-19 patients that are clinically stable, so not ICU or outpatient care patients, was exaggerated during the last or during the pandemic, basically? Did many clinicians oversize the risk that compared to the actual risk? What's your take on that?
Well, potentially. At the same time, there was, at least in the very beginning of the pandemic, I think it's reasonable at least to err on the safe side. But at that also, you need to be mindful of your practice. So based on the first 3 studies that showed an increased and high incidence of VTE, I mean, the reasonable sort of reaction to that would probably be to lower your threshold for investigating VTE in the COVID positive population. But at that same time, I would also say that you should be mindful that you change your sort of evidence-based diagnostic approach, and that should also be evaluated. So, and that's a problem, and that's what we thought, or we saw as a problem, that we likely changed our practice a little bit due to COVID-19, but we really didn't follow up if that panned through, so that actually made sense for other populations than those studied. So that's, I think, was the problem that I saw, or we saw, that sure, it was reasonable to change your clinical judgment or suspicion for VTE in specific populations, but that should also urge you to really check if that change really made a difference. Because otherwise that's yeah.
Daniel?
Sorry, might I also comment very quickly? I just amused myself with doing a basic plot of the prevalence of the word blodpropp, blood clot, in the media archive, which covers most of the national newspapers and local newspapers in Sweden. And there is actually an exponential increase in the prevalence of that word over the pandemic. So I think also there might be a psychological aspect to this, which none of us have obviously addressed in our studies, but which seems quite obvious when taking just partaking in the general discussion in the society, and that many people are worried about blood clots. And I think, unfortunately, that might also affect our practice as physicians at times, that if we hear a lot about the symptom, a lot of our patients will also ask us about it, and that will definitely push us in the direction of maybe suspecting something a bit more often than we would do normally, although we try to keep our heads straight. So that's just a slightly sideline comment, but anyway.
Thank you. One more question came in the chat to the Umeå study. Did you look at regional differences? In the beginning of the pandemic, the recommendations of prophylaxis for ICU patients differed a lot between regions. Did you see any regional differences?
We actually didn't look at that, but that's an interesting point. We have the data, so we could look at it.
Okay. And Jens,
can I just say?
Yeah, of course.
We didn't look at regional differences, but we did look at what the situation was in the same area as the Linköping study, and found results which were very similar to the ones for the study as a whole.
Thank you. Jens, you had a question to the Umeå group as well.
Yes, thank you. I'll have a question about your control cohort, because I struggle a little bit with how this was selected. I understand that the SCB did the matching, and that they matched on essentially sex, age, and counter residency. But because you to derive the incidence or the change in prevalence of VTE, you use the control as a matching group, and at least, and it's a little bit hard for me to understand in which sentences you refer to only new or first time VTE, and then secondary, or as well as a secondary VTE and one that's previously had VTE. Because in your first, when I just look at the numbers, it seems like that the control group has an awful few VTE, or at least a lot less expected. As Ulf pointed out, the base rate of VTE in the general population is somewhere around 200 per 100,000 in Sweden. And during the first wave, the prevalence in your study was around, or per year, was around 20 in 300,000. That might be just because it's first time VTE. but it seems quite few. So what do you think? So the question really is, how did the SCB do the matching? What did they just randomly select based on personal IDs, or how did they actually do the matching? Do you know that?
Yes, I do, and I'm going to hand over to Paddy afterwards to answer your question. But first of all, SCB's Statistics Sweden, they identified individuals that had not tested positive for SARS-CoV-2 at that time, and it was matched in age, sex, and county of residence. That was how they matched it. And Paddy, we had a discussion where you actually you answered the question that Jens was wondering about.
Yeah, I think, I think we're talking about annualized rates here.
Sure.
And I think the figure that Ulf was referring to is about 191 per 100,000. And I mean, if you use the controls from our study and annualize the rates, you get 136 per 100,000. So, and these are first VTEs. Now, they're not going to be exactly comparable because they're in a matched population, which might differ in some ways. But I mean, I think it's the same, it's a similar ballpark. So I don't see any big problem there. One thing I would say is that you have to be careful in choosing your control. Some studies have chosen COVID negative patients as controls. Now, the problem with that is that they might have been symptomatic due to other conditions, some of which might be infections, which might have also increased the risk of DVT. So we wanted to choose in a sense, a kind of a genuinely sort of population base, and that's why we went for what we did.
Okay, good, thank you.
Okay, thank you very much. No more questions from the audience, and I think we're getting to the end of our seminar.
I have a short question.
Yes, please, Ulf.
I thought it was interesting with the different risks and the different waves. What is the likely reason for these differences? Could it be different virus versions or different diagnostics, or might it be just chance alone, or?
Well, my hypothesis has been that the treatment guidelines has also changed throughout the different waves. So I was actually expecting the risk or the relative risk to at least decrease. I was a little bit surprised by pulmonary embolism that was high during the part of the third wave that we have data for.
Yeah.
And if that's the virus type, I don't know actually. But what I also found interesting is that the bleeding risk was not statistically different from the background population, but it didn't increase either over the pandemic waves, which I would have thought that if you're increasing the thromboprophylaxis, that you would then have increased risk of bleeding in the different pandemic waves, and we didn't see that. So yeah, I don't know, Paddy, do you have any comments to that?
I think it's unlikely to be a statistical fluke. I think the effect of certainly for DVT is just too big to be down to that, and I'm not really qualified to comment on any other possible reasons.
Okay, thanks.
Okay, thank you. Yeah, we're getting to the end of our seminar. I'd like to thank all you participants and also the listeners and audience. And I'd like to thank Svenska Läkaresällskapet for inviting us to hold this seminar. I myself, I learned a lot during this seminar, and I really enjoyed listening to you all. So thank you very much, and I hope we'll have a really interesting COVID-19 conference now. Goodbye, everybody.